Audio check, 1, 2. Audio check.
Porque si puede hacer una excepción, muchos países podrían decir,
No me lo voto. Buenas tardes. Good afternoon. Hello. ¿Dónde están los demás ministros? No los veo. Start please taking your seats, the delegations in the main rows. Please. We are starting in a couple of minutes, so
¿Llegó Chile?
llegó Chile.
Ok. ¿Quién está
Where's Jamaica?
todavía?
You have to have someone to get it, Jamaica. Bueno, él es el último, podemos empezar. All right, good My name is Marcos Espinal. I think you know me already, so it is a pleasure to moderate this briefing on the accelerating action for NCDs to primary health care. Let me, before I pass we have an exciting program leading it by Dr. Barbosa, followed by a couple of staff from PAHO, Director of NCDs and the Executive Manager of the Regional Revolving Funds, followed by a panel of 3 honorable ministers and representatives from countries. But before I pass the micro to Dr. Barbosa, let me just remind or refresh your memories a little bit and pay tribute first to the Caribbean countries because of their efforts in raising this issue of NCDs. 10 years ago, they were basically the trailblazers in making sure the UN had its first UN high-level missions on non-communicable diseases. So kudos to the Caribbean countries for their leadership. At the same time, I wanted to pay tribute to the predecessor of Dr. Barbosa, Dr. Carissa Etienne, for being visionary and creating the first non-communicable diseases department within PAHO. So, and today, as you can see, we're going to talk about integration of NCDs. So we are getting into the next steps. So well-deserved tribute for the Caribbean countries for leading the process with UN Secretary General several years ago on NCDs, and Dr. Etienne for following path and creating the first NCD department in PAHO. Without further ado, I'm pleased to introduce the Director of the Pan American Health Organization, Dr. Barbosa, not without reminding you that there is translation available in the 4 official languages of the Pan American Health Organization. Thank you. Dr. Barbosa, the micro is yours.
Thank you, Marcos. You see that today is a non-communicable disease event, so the lunch is much healthier than yesterday. Yesterday was an elimination, and was trying also to eliminate us. Yes. But thank you again. I think that's a very important session for us. I want to thank the ministers that are here, the representative of the ministers, our colleagues from PAHO. Thank you all for joining us today in this briefing session to present for the first time the initiative for better care for non-communicable diseases, accelerating action in primary health care. This initiative aims to strengthen the integration of non-communicable diseases management, building upon existing efforts with a steadfast focus on reaching the underserved, guided by the principles of equity so that no one is left behind. Non-communicable diseases, regrettably, claim 81% of all lives lost in our region, with a third of those deaths occurring prematurely between the ages of 30 and 70 years. Another staggering estimate shows that 240 million adults in the Americas grapple with at least one NCD, necessitating continuous care. It is our collective responsibility to ensure that these individuals have access to enabling environments, policies, and interventions that promote health and optimal care. This access is vital not only for preventing these diseases in future generations, but also for preventing complications and premature death in those currently living with one or more NCDs. Our commitment is crucial to empower them to remain healthy and productive members of society, contributing to the social and economic well-being of their families, communities, and nations. Cost-effective initiatives for NCD prevention and control are well established, comprising policies and regulatory interventions aimed at curbing tobacco use, addressing harmful alcohol consumption, promoting healthy diets, and encouraging physical activities. Equally crucial is the provision of care, which includes screening, diagnosis, and treatment for the 4 principal non-communicable diseases at the primary care level, with seamless referral to integrated health services when necessary. These are cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases. The gains we achieved through global and regional NCD action plans have been significantly disrupted by the COVID-19 pandemic. The pandemic also led to widespread disruption in health services, resulting in delayed and, in some cases, foregone care. Furthermore, individuals with existing NCDs were at a heightened risk of complications and mortality when infected with the novel coronavirus SARS-CoV-2. As our region embarks on the path to recovery from the pandemic, there is an urgent imperative to strengthen primary health care services, particularly for the management of NCDs. The successful implementation of NCD policies and interventions will not only save lives and increase human capital, but can also yield substantial cost savings, alleviating the economic burden on healthcare systems, families, and societies. Globally, only 14 out of 104 WHO member states, with a solitary member in the region of the Americas, are projected to achieve the Sustainable Development Goals target of reducing premature NCD mortality by a third by 2030, relatively to 2015 levels. This alarming statistic highlights the evidence disparities in the availability of quality health services in the Americas. A mere 57% of our member states report having guidelines or protocols for managing common NCDs through a primary care approach. Furthermore, only 26% of countries report offering drug therapy, including diabetes control and counseling for eligible individuals at high risk to prevent heart attacks and strokes. Our region has made commendable progress in addressing NCDs, and here I want to underscore the advances in the implementation of the Hearts in the Americas initiative to improve hypertension control at primary care level. Nonetheless, we must acknowledge that our current efforts will not allow us to achieve the SDG goal, as our region is not on track to meet this critical target. Therefore, we must rapidly build on upon our achievements by scaling up efforts to improve the quality of care for diabetes, asthma, other chronic respiratory diseases, and cancers amenable to screening and management at the primary health care level, such as cervical cancer and childhood cancers. As we progress in our efforts towards recovery from the pandemic and strengthening primary health care and integrated health services in the region, the call of the Astana Declaration for services to be of high quality, safe, comprehensive, integrated, accessible, available, and affordable for everyone must be our guiding principle. These are urgent priorities that demand our immediate attention. It's with immense pleasure and anticipation that I welcome you to the launch of the PAHO initiative, Better Care for NCDs, Accelerating Action in Primary Health Care. I urge all of us, as dedicated stewards of public health, to join hands in this vital mission. Together, we can make significant progress in tackling NCDs, improving the lives of millions in the Americas, and advancing the cause of health for all. Thank you so much.
Thank you, Dr. Barbosa, for setting the tone and leading the way. And as you rightly said, yesterday was communicable, today is non-communicable, which, we all know that it's now leading the way in terms of epidemiological profile in these regions of the Americas as the #1 major crisis and disease burden. So certainly we'll have an exciting 1.5 hours here. Now, let's hear from the launch of the initiative. Let's hear from the initiative itself, so you learn the details and how to take it forward at country level, because the most important thing is the honorable ministers and honorable delegations go home with clear information about how to take this forward We are not going to get there unless we integrate and make sure NCD care prevention services are at the level of the first level of care. Because otherwise, if it remains in the third level of care, then we're not doing our job. Let me introduce Dr. Ansel Hennis, Director of the Non-Communicable Diseases and Mental Health Department at PAHO. Ansel, the floor is yours.
Thank you so much, Dr. Espinal, Director, members of the head table, honorable ministers, colleagues from PAHO, ladies and gentlemen. It's indeed a privilege and pleasure to be here. I'm going to share the podium today with my colleague, Santiago Cornejo, to speak about Medicare from NCDs, accelerating actions in primary health care. Now, this initiative aims to strengthen the integration of NCD management, building upon existing efforts, as you heard from Dr. Barbosa, promoting quality improvement in services to accelerate efforts towards achieving Sustainable Development Goals in NCDs, that's 3.4, as well as in universal health coverage, that's 3.8. And really with a priority perspective on reaching the underserved, guided by the principles of equity so that no one is left behind. This is an interprogrammatic program within PAHO that includes several regional office departments, which will work in close collaboration with sub-regional entities and, of course, principally the country offices to scale up technical cooperation in member states on non-communicable diseases. This slide shows the principal elements in terms of the conditions. So I'm going to work my way from the orange bar, which is cancers which are amenable to screening and diagnosis and even treatment at primary health care level, so cervical cancer and breast cancer. The purple block shows the management of asthma and its exacerbation, as well as chronic obstructive pulmonary disease, which is another priority area that we'll be looking at as well. Health education and counseling on risk factors, including tobacco cessation, cardiovascular risk assessment and management, as well as hypertension management. And as you heard from Dr. Barbosa, there's a tremendous initiative already in the region on the Hearts in America's initiative for hypertension management and control. The other topic of priority is that of the management of diabetes. So these are the elements that we will be tackling in terms of working in member states to scale up the management of these conditions at primary health care. This big slide, which is really hard to see, shows the overall guiding framework for primary health care planning and evaluation. You'd see over to your right the health system determinants, which include governance, adjustment to population needs, financing, inputs, which are infrastructure, health workforce, medicine and health technology, etc., digital technologies for health. And these determinants feed into the service delivery and related processes and outputs and result in the achievement of the objectives of universal health coverage, which include health security, improved health status of the population, equity, and responsiveness of health systems and services. That's quite a lot to go through. So we are going to be focusing this initiative on quality improvement of health services. The key components being integrated people-centered care in terms of the processes, systems, service design, organization and facility management, etc., systems for improving health quality, and of course, strengthening health facilities so that they're resilient. And you know, PAHO's done a lot of work in this particular area. This then leads to increased access and availability in terms of service availability and readiness and utilization of services, and the output being improvements in quality care, which is ultimately what one aims to achieve. And you can see in the slide the different issues like improving first contact accessibility, continuity of care, comprehensiveness of care, coordination, people-centeredness, which must be at the core of this initiative, as well as effectiveness, safety, efficiency, and timeliness of service provision. These are things which I know resonate with all of the ministers here. Now, what is the definition of integrating NCDs into primary health care? We're using the definition of NCD screening, diagnosis, treatment, and monitoring being integrated into the health system in an equitable manner. at the national, subnational, and local levels. So it has to reach people where the needs are there. So in other words, you may find in urban centers areas where health systems are really very good, but then pockets of poverty related to access and availability of quality of services. And then, of course, is the urban-rural divide. So the idea is to strengthen services where you're reaching those who are underserved in the most efficient, optimal, and equitable way. So this takes place at the first level of care through improvement of comprehensive services, improving first contact and coordination of care with linkages to the community. Because clearly, if the community is not accessing services, they will not benefit. Then, of course, one has to take a life course approach. And as we heard, in terms of the resolution that was approved yesterday, NCDs have to be tackled at the time even before birth, and throughout youth, childhood, adolescence, and young adulthood, before habits are established. Then, of course, one needs to have a surveillance and monitoring framework to assess how you're doing and do the necessary course correction. Definition of acceleration of integration of NCDs into primary health care. This is based on prioritization of an equity approach, territorial planning to address gaps in coverage, access, and quality. So it's not just the big picture, it's drilling down to the specifics where care is needed and where there are gaps in care or care is not optimal. Then there's the national, subnational, and local expansion of service delivery capacities and resources. And the fourth component is to establish or expand capacities for coordination and continuity of services. And that, of course, means that services don't only stay at the primary health care level, but it's an integrated approach so that if additional care is required at the secondary and tertiary levels of care, there is the necessary referral and contact referral that accompanies this. So, the purpose of this initiative is to expand equitable access of integrated and comprehensive NCD care services within primary health care, to strengthen the capacities of health authorities to plan and implement comprehensive NCD services of primary health care, to increase the capacity of primary care services to deliver comprehensive quality NCD screening, diagnosis, treatment, and continuous follow-up care, which includes referral and contact referral, and highlighting the key importance of utilization of quality integrated health services, and also, of course, to strengthen data collection and monitoring of all elements of care for persons with NCDs. Now, this initiative is built on 6 strategic areas. I'm going to work my way from number 1 to the top, which is development of country plans for scale-up and expansion of comprehensive NCD services and primary health care, including telehealth. And we've already started working on this component. Community outreach to reach underserved populations, strengthening service access, health promotion, and health literacy, updating normative guidance, including quality of NCD care and improvement of management, primary health care workforce development for NCDs, which means strengthening multidisciplinary approaches for NCDs, among others, as well as patient journeys and patient pathways of care, expansion of NCD medicines and technologies, and improvement of NCD information and monitoring. This slide gives you a little bit more detail in terms of the actual components. So, the rapid assessment is to evaluate the existing solutions and situations in countries and develop roadmaps, which includes the integration of telehealth services. And this is the strategy working jointly with countries to accelerate NCD care. In terms of community outreach, there will be the development and implementation of tools to improve participation in NCD services, reaching underserved populations, and also promoting health. The third component is normative guidance, which is evidence-based guidelines, care pathways, and country adaptation processes. Fourthly, primary healthcare workforce development, which requires tools for workforce planning, as well as a training and mentorship program that I'll give you a little bit more detail about shortly. Strengthening essential medicines and technologies, and this is coming up with the novel idea for NCD bundles to the regional revolving funds and expanding the offer. And sixthly, information and monitoring, strengthening the data architecture within facility-based essential health platforms for data management and patient monitoring. Now, I'm going to take you through one by one, country plans. So this really comes down to a joint PAHO country assessment of the situation and development of scaled-up plans. We have been working on developing an NCD primary healthcare assessment tool and made a lot of progress in this space. And this is a strategic planning tool for the assessment, identification of gaps, and priority setting. And this, in turn, will allow the countries working jointly with PAHO to develop guidance for implementation and mapping through a menu of actions to accelerate integration of NCDs into primary healthcare based on the results of that assessment. Then community outreach. So this community outreach really is based on tools for promoting access to services, which includes a suite of health promotion and NCD prevention educational materials. NCD guidelines. Now, there's the existing WHO PEN packages. We've reviewed this in detail and have embarked on a process to develop evidence-based guidelines for the Americas, which is adapted from the WHO PEN. And this is going to consist of updated best practices, multidisciplinary approaches, and cross-cutting themes which are relevant to the Pan-American Health Organization region. It will be a living document. So in other words, it will be continually updated with the best practices, the best evidence, and shared experiences from the region. There will be leadership and guidance from EIH, which is our Information for Health department, which will assist with the country adaptation processes. Then the fourth pillar is primary healthcare workforce. The components here are a workforce planning tool, and this is based in terms of strengthening the situation analysis and workforce capacity, gaps, needs to strengthen care delivery, as well as building capacity through training programs through the PAHO Virtual Campus. This here lists educational materials that are already available. They are highlighted in the black. So you can see, and we have divided into 3 tracks. A clinical track, which includes hypertension. We're developing training tools in diabetes, asthma, cervical cancer screening, and breast cancer early detection. A public health track. We already have materials and community health workers training on NCD prevention and tobacco cessation, but the others that we're going to develop and we're in the process of doing. And the third track is data and monitoring, which includes facility-based monitoring and digital literacy. This slide speaks now to the 5th pillar, NCD medicines and technologies. And in this particular area, you can see the major diseases highlighted: diabetes, cancer, cardiovascular disease, and chronic respiratory diseases. And it looks at the medications that will be available through the regional revolving funds for diabetes, which includes insulins, sulfonylureas, as well as SGLT1 inhibitors. In addition to other technologies such as blood glucose monitors, as well as blood pressure measurement devices. For cancer, we are working in terms of including in these bundles tests for screening for HPV, for the detection of cervical cancer risk HPV variants, as well as thermoablation technologies, as well as medications for hypertension control and lipid lowering, as well as medications for chronic respiratory diseases. You'll hear a little bit more about that shortly. And the final limb is that of information and monitoring, which means strengthen the data architecture for facility-based reporting, as well as recording information for facility performance. So these are the different pillars. The inputs, as you can see there, are standardized guidelines, core medications, technologies, and primary care workforce. And ultimately, we hope to improve blood pressure control, blood glucose control, reduce complications, improve asthma and chronic respiratory disease complications, reduce emergency visits, and of course, improve outcomes for health. At this point, I'm actually going to invite my colleague, Santiago Cornejo, to present a bit more on the revolving funds. Thank you.
Thank you, Ansel. And yesterday I mentioned how the Revolving Fund for Access to Vaccines and the Strategic Fund for Essential Health Supplies are working together to achieve the 4 goals to improve access. These goals are accessibility, which is equitable access to hard-to-procure and new technologies; affordability, which is access to cost-effective interventions and leveraging our economy of scale; availability, which is maintaining a consistent and reliable supply of the right technologies at the right time; and quality assurance. Of course, the achievement of these goals relies on the solidarity efforts of the region. Hans already talked about the portfolio that we offer in this bundle, which includes medicines and essential health technologies based on WHO and PAHO's guidelines, methodologies, and principles that should be accommodated to each country's context. Our technical assistance cooperation initiatives are there to support, to accommodate this portfolio to your country needs. Now, how did we achieve this bundle? So we took into account the WHO list. If they are not in the WHO list, then we look at national medicine list of the region. We also must have qualified suppliers that will supply to this region. We take into account intellectual property assessments because we know that each country holds different patent landscapes. And finally, we assess the feasibility of that consolidation of demand will provide a value add to you. Let me now, like yesterday, give a few examples where we can show the additional value of consolidating demand. This is an example of a medicine for diabetes that many of you buy usually locally. Now, we have been working with a few member states in an ad hoc basis, and even then we were able to reduce the price by 85%. We believe that we can decrease the prices even further if we can consolidate all of your demand on a timely basis. Yesterday, we talked about the agenda of cervical cancer elimination, and as Amsel mentioned, the tools are part of the NCD bundle. Many countries are starting to the implementation or expansion of the number of tests to detect cases. But we noticed that the prices are high and availability is low. We have already prices which, as you can see in this example, are 60% lower, and we believe that they can help to increase access. During the meeting, many member states praised the HERTS initiative. Now, we have a success story with one medicine in HERTS in the price that we achieve, which is 99% lower compared to what is in the market. It is important to count now on country solidarity to achieve similar effects in other treatments. For example, we believe if we can consolidate the demand for losartan as a fixed combination solution, we could have a similar impact. Finally, one of the strategic pillars of HEART is blood pressure monitoring. For electronic blood pressure monitoring, we achieve an 80% reduction in price compared to the market. And these are monitors that meet international quality standards. This is an example only to underscore that we can have an impact in improving access and affordability for devices and other health supplies, and not just medicines and vaccines. Previous examples show the benefits of consolidating demand, not only for one country, but for the region. You are now updating your treatment guidelines based on WHO recommendations to optimize treatment schemes. It is a great time to consider participating in the regional revolving funds. This is my call for action today. Yesterday I mentioned the technical cooperation that we provide to help you consolidate the demand. Let me very quickly talk about the other two initiatives. The digital journey is improving and simplifying the demand consolidation process. Now you have a portal that replaces many Excels to request your demand, where you will find the data in one place, not just for this year, but for previous years. We are also working for a to share financial information through this portal, like statement of accounts, at the end of this year or early next year. And next year we will work to include tools for tracking procurement. The credit line is a unique element available through the funds, one that you contribute with each time that you procure, a true example of solidarity. This is a credit line with 0% interest that you can pay 60 days after receiving the goods. We're also working to improve the process to speed up and reduce bureaucracy in order to access the credit line. These improvement initiatives are also examples of the director's priority to increase efficiency in the way the organization works. Let's improve together and address NCD bundles in primary health care through the Regional Revolving Fund. It's a comprehensive approach to addressing diseases in the Americas. Please visit us in the booth to learn more about the revolving funds and the NCD bundles, and also you have your QR code there in the table with you, so you can have the initiative, the report of the initiative. Thank you very much.
Muchas gracias, Santiago.
I'd like to thank Santiago.
That because the two presentations made available to the delegations through GBO or through the website, so they can digest, as you rightly said, Ansel, some of the slides a little bit packed. So the delegation would like to have those so they can contact and talk to the, please. Oh, that's a nice one. Yeah. Thank you. So we're going to make available the presentations, and please visit the booth of the strategic fund and the revolving fund so you can receive more information. Now we're going to go to the main course, the panel of ministers and representatives. Tengo el grato honor de
It is my great honor to begin the panel with Dr. Raquel Child, who will talk about primary health care expansion for the prevention and control of NCDs, also including addressing social determinants for health. Dr. Child represents the Honorable Minister Jimena Aguilera, Minister of Health, who had to return to her country earlier. Dr. Child, please go ahead. The microphone is yours. Thank you very much. Tupaho. For this opportunity to talk about our policies, our historical policies, actually, to tackle chronic NCDs. And non-communicable is another concept that can be also debated. Obviously, I want to convey to you the greetings of Minister Dr. Jimena Aguilera, a great friend and partner of the Pan American Health Organization, who had to leave last night to return to Santiago. We are presently spearheading a reform in Chile so that primary health care can be the fulcrum for the response in the country So we hope that the Chilean Congress will approve the proposal brought forward by President Boric's administration, so the primary health care will be the fulcrum for the health response in the country. In this context, where primary health care will be the fulcrum for Chilean response when it comes to health issues, we have the vision generated by WHO for the entire world, actually. And this WHO vision gives a priority to tackling the NCDs. And as we just heard from Dr. Yarbas, the PAHO director, it's under the plan of 5 for Fine. This includes cardiovascular disease, diabetes mellitus, cancer, COPD, and mental health. And they share 5 risk factors in their genesis. We understand that the existence of NCDs has a population perspective, where the factors having impact on health are often related to the health system as well as with individual behaviors, social practices, and economic conditions. That is why we believe that the response to these problems of chronic NCDs requires multi-sectoral coordination and interdisciplinary work in order to respond to the problems from a focus of health social determinants. As you maybe know, Chile has for many years tackled NCDs through primary health care. At first, through blood pressure and diabetes mellitus control programs, but everything was done in isolation. What we are now doing is enshrining it all in a single strategy, as I said at the outset. Beginning in 2005, so that's quite some time back, in the context of the health reform that was carried out at the time, a reform that resulted in access and timeliness for care to people with diabetes, high blood pressure, ischemic cerebrovascular disease, COPD, chronic kidney disorders, and others, were incorporated in the what we call the GES, a law that explicitly provides coverage, a law that guarantees and continues guaranteeing access to preventive consultation in order to identify in the early stages these health issues. But based on this preventive diagnostic treatment, one can then generate health controls and treatments that are necessary based on the outcome of those consultations. Although the resources available to these chronic NCDs have increased and the diagnostic capacity have improved, as well as treatment and follow-up or monitoring of people with these diseases. In recent years, we have noticed an increase in these diseases, and part of it due to the COVID-19 pandemic. This meant that there was a slippage in the indices of illness amongst our population, and this is a challenge that we are addressing right now. The National Health Survey in 2016 and 2017 at that time already presented alarming data that reinforced the need to today prioritize efforts to develop and implement prevention, early diagnosis, and timely treatment policies for these pathologies. Just to give you some example, the survey showed that diabetes was suspected in 2.3% of the surveyed population and 27% that could be carriers of high blood pressure above the age of 15. Today, we believe that approximately 11 million people, and in Chile we have 19 million population, 11 million have some of these non-communicable chronic diseases, and 2 No, I'm sorry, and 2.4% of those individuals have all 5 pathologies. This obviously imposes a major stress on our health system in order to tackle and respond to these needs for our population. So we are presently working on redesigning the process to care for people, especially with multimorbidities, trying to improve the care services, moving from a disease-centered care to a collaborative care that is person-centered, ensuring continuity of care from a perspective of clinical continuity as well as functional, professional, and community continuity. Amongst the activities we are carrying out, we want to improve the quality and number of controls of cardiovascular health through different initiatives on parallel channels, addressing multimorbidity, having an integral care that is person-centered, the Heart's initiative for high blood pressure and for diabetes, standardization and protocol for high blood pressure treatment, incorporation of drugs and new health technologies to provide better care to people suffering from these problems. Training at community level as well as the health teams, and developing guidelines for clinical practice and technical guidance for the more prevalent NCDs. As you may understand, at the center of these initiatives, we have developing capacities in the population and health teams. And at present, training is targeting people in rural areas with the purpose of standardizing the measuring blood pressure in the hopes of reaching the entire population in these remote areas. Another strategic pillar for developing primary health care is work based on a multidisciplinary team where all the technicals and professionals in health are being trained in standardized blood pressure measurements so that in every contact with a user who attends or goes to a health center, these parameters can be measured in a reliable way. We have also provided legal support so that this action of non-medical personnel may deliver therapies according to protocols standardized by the Ministry of Health. At present, it's only doctors who are authorized to conduct this type of control. In order to address a decrease in control of persons with these diseases during the pandemic, and this resulted in increasing complications and increasing the number of hospitalization, such as diabetic ketosis and other problems. So beginning last year, we started recovery in care, and this implied injecting resources to address these persons who had not had controls and also to be able to identify them. Lastly, the challenges that we face as a country to accelerate control, well, we have several. Let me just focus on 3 that have a different importance. The approach of NCDs requires governance of the system plus reorganization of services and their financing to ensure comprehensive management of health issues, focusing on the needs of persons at the primary health care level. On the other hand, we need to finalize and implement a plan for response to NCDs, emphasizing, as I pointed out earlier, the promotion, education, and primary health care and delivery of services, focusing on intersectoral work. And lastly, increase access to health technologies related to drugs that are more effective, as shown by existing evidence to address diabetes mellitus and high blood pressure. Thank you very much.
Bien, continúo en español. Muchas gracias.
We'll continue in Spanish. Thank you, Dr. Childs, for a very good presentation of the progress achieved by Chile, but also everything that's being done and the challenges that you're trying to address. And you're showing us the way forward, actually. Changes to governance of the system to have integrated management and intersectoral work as part of a response plan. And that is truly crucial, that governance, those reforms, they need to take into account non-communicable diseases because the communicable ones have a long-standing history in the region of the Americas. So thank you. It is now my pleasure to continue with the Honorable Minister of Health of El Salvador, Dr. Francisco Roselavi Montoya, who will be talking about heart to control blood pressure and talk about the progress achieved through the heart program. Minister, the floor is yours. Good afternoon to all the delegations. It is an honor for us to be able to share with you what has been done in El Salvador through implementation of the heart strategy. It's important to realize that through this support and this integral strategy of primary health care that the Pan American Health Organization it continues offering us today, but especially underscores the importance, and people therefore can achieve major results, which is what we are going to show you. The heart strategy is simply, of all those that are being considered in El Salvador, focuses on the 5 points mentioned by Dr. Barbosa, focusing on cancer, diabetes mellitus, also looking at respiratory diseases, and of course, mental health and high blood pressure. Implementation, as you know, is not only through the health system. The health system in El Salvador is fragmented, but there's also Social Security, National Health Service, and private entities. And on this slide, we can see what makes up the health system. We have a little bit of information that we have 5.5 million of deaths are caused by NCDs of the 6.9 million total. El Salvador has about 71% of deaths due to NCDs and 38.2 are premature. And it's important to understand this. The strategic framework in El Salvador comes from universal free coverage by the health system. There are no restrictions whatsoever for the population, even for the population of neighboring Central American countries who can receive all these services. And the priority aims to avoid premature death, avoid cardiovascular metabolic complications, cancer, and premature death due to chronic kidney disease through these plans. The Plan 2019-2022, a 2020-2023 health plan, and the Institutional Strategic Plan 2021-25. Why am I mentioning this? Well, it's so important. We see that through tackling health, we talk about cancer, diabetes, high blood pressure, we talk about pulmonary diseases and mental health. But there's something else that we need to consider because it affects the Americas, and in particular Mesoamerica, and this is chronic kidney disease. This is still a very important issue to be borne in mind that is strictly linked to metabolic pathologies as well as high blood pressure that we're all familiar with. The heart strategy in El Salvador, well, you all know the pillars focus on habits, lifestyles, evidence of protocols, access to medication and technologies, cardiovascular risk through stratification of the disease, work based on multidisciplinary teams and monitoring systems, and these have been implemented in a very short time. What are the key drivers that we identified? These are described: precision in measuring blood pressure, cardiovascular evaluation, standardized protocols, intensifying treatment, continuity of care and monitoring, transfer of skills, frequency of medication, and evaluation system. All of this is important. In order to obtain these results, there was something very important that the country has been done since the beginning of President Bukele's administration, and that is digital transformation of the health system, without which it would have been impossible to move forward with this and other strategies. And this has been linked to direct support and financing to attain that objective, signing agreement with Google. We are wanting to overcome the barrier for primary health care. This ought to be implicit under the four walls of the establishment. Universal access can be attained, but primary healthcare can be totally digital. 80% of diagnostic and treatment and control of hypertension. That is what was established. This is the road we took. El Salvador began planning, then formalized a commitment with the strategy on 18 August 2021. In 2022 and 23, these were the years for implementation of the heart strategy, and we are now in a point of maturity for evaluation. You can see on this timeline, 2024, implementation of strategy, incorporation of new strategies, validated digital outcomes, and everything that's included in the strategy. This was based on a governance structure to implement the strategy. It came out from the minister through a national commission for NCDs. It was implemented through teams and became operational on a regional basis using the health institutes, which is the functional way primary care is delivered. Not only did we have the Ministry of Health, but all the government entities that were strictly related to health issues, as well as associations, municipalities, civil society. Also, academia played an important role, and of course, the Pan American Health Organization cooperation. We know this strategy is a matter of packaging the good practices that would provide good results in a unifying way to manage hypertension, and today in the country we have important results.
Implementation is on the basis of the national integrated system. We have 81 hospitals distributed throughout the territory, and we have about 764 health units as well. As you can see, the last 2 years represented the 4 implementation stages of 2022. First semester, first phase, second half of 2022, second phase, third phase was the first quarter, half of this year, and the last one will be the next half. What's important, what we can see here currently, the entire force of health workers has received information and training. Of these, we have certified 8,776 out of the 12,396, which represents 70% of all workers are certified through the resources made available through this strategy. 1 academic hour, 1 virtual course on how to take blood pressure, 25 hours of managing hypertension, and academic package that is only for the head staff. We have a platform where 70% has been certified. Clinical guidelines, we have standardized them. Here you can see the one on blood pressure, high blood pressure, but we've also made the same for diabetes and chronic kidney disease. This is a way of standardizing the management for each health worker so that the work is efficient and the results can be obtained. We now have automatic blood pressure cuffs that have been validated in 100% of the health centers, as well as coverage for connectivity has been provided. And so we have 100% digitalization in the health units of the Ministry of Health. We have standardized the information data. We know that the MD DHIS2 platform of PAHO, the equipment teams have been trained by PAHO, and we have all the necessary information so everybody's fully informed of what is happening. Here's our integrated health system. Our digital platform on health was developed in El Salvador, and it provides total coverage to all health units so that we can adapt it based on the daily needs of workers in the country. Here's the roadmap. Again, here are some pictures of how it works. Not only do we have a digital transmission or care, remote care, in the hospitals, but everywhere, in the kiosks, in the surgery rooms, etc. We have what we achieved through the traditional system. We've achieved through digital internet. We work based on multidisciplinary committees. For the nurses receive training and perform the original screening. The pharmacists work in the most remote areas of the country and identify cases. We have provided counseling for the pharmacists, and the pharmacists are able to provide information to patients. What is the maturity of the program? We're at the level of 15. These are the outcomes based on all the scores. What has been the performance index in implementation of HEARTS? Our standard of 2.58
desempeño en un corto.
is a high performance index over a very short period of time. We started in 2021 and it was implemented in 22 and 23. 70% of the staff is fully certified. Progress in implementation. In governance, we've reached 4 points. Blood pressure cups at 3.5%. We're still completing the validation of the rest in areas which are used not only in primary healthcare, but also in hospitals. Medication, 4 points. Not only have we included combined medication as recommended, lisinopril and amlodipine, but also certam amlodipine and others for diseases such as diabetes mellitus and cancer. Clinical way 4.0, drivers 3.5. You can see a total of 3.8 out of a total of a score of 4.0. What's the result? And that's what's important. We've seen that in 2019 to 2023, there was an increase of 39.6% of the to 81.3% control of high blood pressure. And I think this is significant because it shows that we are implementing what PAHO has established through its HEART strategy. All we're doing is benefiting and using that HEART strategy. The trend of premature deaths has decreased. We have 303.2 per habitant in 2021, and currently that has dropped to 270.6 by 2022. We know that there are a lot of issues that had to be considered because of the pandemic, but I think the results are quite significant. The premature death for cardiovascular diseases have also decreased to 136.2%, and El Salvador, like other countries, years ago had great difficulty in having information about what was actually occurring. So now our data, the data for past years is quite deficient information, but now as a result of the development of the health system, we've seen improvement in data obtention. We have interoperability with the platform. We have a quick, rapid, direct communication of our own system with the platform, which will in turn decrease any delays in consolidating the SIS information to upload it to the PAHO system. We've been working on strengthening specialized teleconsultations. We hope to become a country where primary health care will not depend on walls or on being able to go to a facility, but to be able to do so through a consultation by their phone or the many other internet mechanisms. And like Chile, we're also in our parliament in trying to get them to amend Article 19 of the law, which would allow us to increase having healthcare workers to prescribe combined treatment for high blood pressure. This is the HEART strategy that was implemented over a very short period in El Salvador and is having some significant results. Like this strategy, we should do the same in diabetes, in cancer, or with COPD and mental health. And I think the best way of achieving that is by identifying something that does work, then structure it, put it into a strategy, and then apply it in the different countries of the region of the Americas. Thank you very much.
Muchas gracias, honorable ministro.
Thank you, distinguished minister, for this excellent presentation showing us the progress that has been made in implementing hearts. And as you said, it's not just in the area of hearts, but progress has to be made in cancer. And that's where we have to make sure that all non-communicable diseases benefit from the same effort we've made in hearts.
To introduce the Honorable Christopher Tofton, MP, Minister of Health of Jamaica, Minister of Parliament, on leveraging innovation in digital solutions, including for NCD control and prevention. Honorable Minister, the mic is yours.
Thank you very much. Director Barbosa, other distinguished members, ministers at the head table, Mr. Chairman, distinguished ministers, delegates, ladies and gentlemen in the audience. First of all, let me just commend PAHO on this this workshop, if you will. I think there are a lot of lessons to be learned, and I think it's a very positive development in the spirit of collaboration. Jamaica, like the rest of the countries of the Americas, faces the same challenges around NCDs. The data is very similar, and therefore the response and the extent to which this represents a crisis is impatient of debate. The issue is, how do we move forward to addressing the challenges? Now, the NCDs is a clear and present danger, and for us, the approach is that the solution doesn't just lie on a prescription pad in terms of the provisions of medical care, clinical care, medicines. The fundamental solution really lies in how we change behavior and get our countrymen and women to deal with health-seeking lifestyles that addresses some of the critical requirements for longer life and better quality of life. And the issue for us is, how do we engage technology, which is the subject of the conversation, to dealing with influencing behavior. And data represents a critical part of that. So in the first instance, it's about how we adopt innovation using digital technology at the regional, country, and sub-regional levels. And these innovations are critical. So we start from the standpoint of partnerships, and we do have very good partnerships. PAHO, clearly WHO, an important partner. But in our case, we have moved towards establishing critical relationships with the Inter-American Development Bank, with the EU, so we have bilateral partners and multilateral partners in examining some of the critical components that are required, leveraging the expertise and securing the financial resources to build out a comprehensive health information management system and data exchange system to support some of the issues that were raised in the earlier discussion. So we are on track for that, and I'll go through a few levels of that. We're also on track for developing and establishing a chronic care model, a comprehensive system for organizing chronic disease care within a network that ensures coordination both between health centers, hospitals, but also personal patient information where the patient can carry their information with them with the use of technology. How are we getting this done? In specific terms, there's a lot of overlapping with what has been said before, but I'll just highlight some of them. Health information management systems. The ministry has implemented an electronic health records system, System 1, from the Phoenix Partnership, which is a UK-based entity, partly financed through the partnership with the IDB, the Government of Jamaica funds, and supported by other partners. It allows a sort of seamless management of exchange of patient information across health centers and hospitals. And NCDs, of course, which dominates the population in terms of our health profile, is a primary base data. So essentially, we are now in the process of networking over 100 health centers across the country. And then on top of that network, we're providing under this arrangement, which is now being implemented, all the critical infrastructure gadgets, the tablets and the laptops and so on, for both doctors and administrators to use. And then we have recently established another contract to put the software on top of that. The end result will be one patient, one record, and that is now taking place. So you go to a health center, your data is uploaded, you end up at another health center somewhere else or a hospital, that data is easily retrievable. So we have the history of your information and therefore able to treat you in a way that is seamless, reducing transaction time and transaction cost. The other is telehealth initiatives, national telemedicine program, which is now in effect. We're going through a number of trials with the intention of rolling that out as a more mainstream. Jamaica is a small country, like so many other Caribbean countries, so we do not have as challenging a time to move from one part to the next, except maybe for our friends in Guyana and maybe Suriname, but for the most part, we can move around. But there are still areas, because of where the concentration of expertise resides. So our University Hospital of the West Indies, which is our tertiary level institution, linked to the university where they do training, that's where most of the specialists are concentrated. If we need an opinion on a patient that's on the other side of the country, then the telemedicine technology, which is now being put in place, allows for that. And that actually is now taking place as we build out the technology platform to provide, again, more seamless response. The issue of shared healthcare records is a critical component of the electronic system, digital technology that is being implemented. And that's sharing information not just between institutions, between experts, from point of contact to another remote point, but also across borders. Because there are partnerships that we enjoy in institutions outside of Jamaica, which sometimes require consultations around patients. And we are in a position to do that, and the technology has allowed us to do that based on what is now being put in place. At the subnational intervention level, regional health information management facilities implemented the electronic health record, which will be able to share health data for patients who encounter challenges within the context of our small island states within the region. We provide services for each other because, as is the case with us not having all the specialized expertise on the island in Jamaica, there are cases where other countries within the Caribbean send patients to Jamaica for treatment. And the process of consultation to determining whether or not that patient needs to come, what needs to be done, and preparation for that procedure is heavily linked to the capacity for information to flow, not just for the people to flow. In fact, the information should flow before. And what the digitization that is now being done allows for is for that information to move from one place to the next. A critical component of the digitization imperative around healthcare is to move it from the higher level of hospitals to primary healthcare institutions, to health centers. And that is what we're trying to do with the networking of our health centers and linking them to hospitals. The big challenge with NCDs, from our perspective, is to get community-based interventions, to prevent as opposed to focus on cure, to influence lifestyle around things like screening, treatment, to control illness as opposed to waiting until you have an emergency and having to go to a hospital emergency room or being admitted. So the credibility of our primary healthcare institutions or health centers is very critical. I can't speak for other jurisdictions, but more often than not, a patient sees a hospital as offering a more credible full-service response than they would a health center, which is a part of them in their community. For some reason, that's the thinking. And one of the real big challenges that we have, which I have not heard mentioned, I endorse everything that has been said, and I think many great examples are here for us to learn from, is how do we engage the concept of change management and change behavior to restore some credibility to the primary healthcare institutions, which over time have lost credibility because they are perceived to be less than adequate in solving the challenges. Because most of us, certainly in Jamaica, and I suspect in other areas, don't see prevention as a critical imperative to their health profile. They see cure after they are ill, and they require it, they demand it, they demonstrate for it. But ask them to do an annual physical, and they think it's unimportant because they're okay until the doctor sees you. And so the change management component is critical, which is why we have said that accompanying the initiatives around technology has to be a parallel strategy to engage a sort of nudging of behavior around the virtues and the value of engaging the institutions where that technology resides and utilizing that institution. And the same for management. There are many institutions that we know are establishing the technology where the doctors refuse to use the gadgets that they're given. They still want to hold the X-ray film under a light to see what the problem is, even though they have their phone that can give them a clearer image of what the problem is. And if we do not embed in this transition towards greater technology and efficiency usage, the change management component is going to be a lot more difficult. You may actually end up with the machines and then not. The other final comment is the concept of personal responsibility. Patient taking responsibility for their health. Again, there is a tendency for us to seek a solution from the relevant authorities as opposed to taking care of what we need to do to protect ourselves. And embedded in that is the use of micro gadgets, technology, that allows us to know our numbers, know the status of our health position. So we launched a program in Jamaica, in 30 seconds and I'll sit, called Know Your Numbers, where we are mobilizing mobile outreach clinics to go into communities. We're actually incentivizing people by giving them discount cards to purchase food or whatever at participating locations. Not alcohol or tobacco, by the way. That's no. To get screened along the very critical components that will determine what their health is. And we're saying to them, know your numbers. That's a big part of the public education and health promotion component. And the idea is to give them those numbers on an electronic card that allows them to own their health records. It's theirs, and allows them with their doctor to determine where they may be off and what follow-up action needs to do. That lies in the primary healthcare system, and the idea of trying to get that conversion to seeing that as a more important intervention than hospitals is where I think our biggest challenge lies. But I do believe we can do that with the technology. Thank you very much.
Thank you, Honorable Minister. I think he saw me with my 2 minutes warning, so. Well, we know we are a little bit behind, but we also started late because the Directing Council was discussing important matters. So, and we still have 10 minutes more to go. So I'm going to allow 5 minutes for any burning issue from the honorable ministers and delegations if they wishes to do so at this time, and then we're going to close later so you can all have time to go and do certain issues before going into the Directing Council. Any questions, comments? I see the Minister of Health of Ecuador. I think it's that. Yeah. Honorable Minister, please. Por favor.
Thank you very much. Good afternoon. I'd like to thank you for having this initiative and for the work that's being done by the Pan American Health Organization, which I feel it's extremely important. I just wanted to add two other points. We've talked a bit now about changing the fulcrum from visible to invisible disease. And there's a lot of experience in the handling of communicable diseases, particularly in epidemiological surveillance of diseases, and that in turn can improve the surveillance of communicable and non-communicable diseases, as well as strengthen the relationship with the community or with other sectors to help focus on determinants. Two examples. In Ecuador, we're working on the community epidemiological surveillance, which was used for COVID, but we now have converted it into surveillance of risk factors, obesity, overweight, in the neighborhood so that the communities can identify it and encourage them to access the HEARTS program to measure their blood pressure and glucose, but also to promote physical activity in the community. So the community can become much more actively involved in the management of disease. Another point is that we have identified real indicators in order to measure progress. For instance, in the case of diabetes, we have a prevalence rate that ranges between 7 and 9.8%, depending on the area. That in turn allows us to identify and set a goal at the first level healthcare centers so that they have a nominal record of all those people who live in the area. And the goal is of identifying an established number of people who have diabetes, which probably are in the community, instead of undertaking general screening programs without any clear goals or objectives. So I think that we can use the experience we have with the surveillance of communicable diseases in the handling of non-communicable diseases. Thank you very much, Minister. Bolivia, please. Thank you. We'd like to thank you for the excellent report that has been presented on this initiative to accelerate the actions for NCDs through primary healthcare centers. In our country, when we set up the single healthcare system, we started with primary healthcare as the port of entry for this single system because we felt that 80% of the pathologies, amongst them NCDs, were able to be cared for and prevented at the primary healthcare level. However, the pandemic has delayed the implementation, and we've had to strengthen the third level of care to deal with this pandemic. But today that we no longer have the pandemic, we've gone back in our single healthcare system to focusing on primary healthcare. Bolivia has a very rich history of working with social organizations and communities, and our country has been doing this for some time now. We're now going back to working with the community to develop primary healthcare strategies, early detection of NCDs, and also to detect changes in behavior. There's no doubt that the pandemic has changed behavior. And for some time now, people with NCDs have not had access to treatment on time, and that has exacerbated their diabetes, blood pressure, etc., even diseases such as cancer in Bolivia. So we are now looking at this again, and at the third level of care, we are undertaking curative actions and implementing very strongly at the primary healthcare level actions to promote and prevent NCDs, working with the community to apply the HEARTS initiative and from the single healthcare system, a system for preventing NCDs. These actions initiated by PAHO serve as a roadmap for us, allowing us to improve and strengthen what we've already started to do. So we do want to thank the director and the sub-director, assistant director for having initiated this, because we as a country are in the process of strengthening our primary health care, which had been ignored a bit during the pandemic period. But we're very proud to say that 70% of our population has free and universal health coverage. And we think it'll be much easier to go back and strengthen our primary healthcare system. Thank you very much, Bolivia. And Ecuador and Bolivia has reminded us of the community surveillance and the behavioral changes that have taken place. I will conclude with Argentina, Madam Minister. Thank you. Thank you very much for the presentations. I just wanted to add to what has already been said by saying that Argentina is also implementing the heart strategy, and we have given primary attention to kidney disease, from early detection up to access of transplant. In other words, we're trying to decrease the dialysis period, which is very significant, and it's very important to work in this area. In that, and in terms of the differentiating between communicable and non-communicable, and when outbreaks occur, and the treatment and trying to shorten chronic disease, all of that presents a challenge which is different from NCDs. Because in NCDs, we have to establish behavioral changes, and that takes much longer time. It is very important to try to get the population to understand that health is important and address it with a comprehensive manner. That's why it takes more time. Here is where industry plays an important role. The food industry, for instance, not just the pharmaceutical industry. We have to get them involved in helping us change behavior. And when we have involved the tobacco companies, the food companies, all of them present a major challenge which we have to include and goes beyond and affects healthcare. So that still presents a major challenge, and the population has to see this change in behavior as necessary for promoting health and improving their own health. In terms of how we can increase impact access to technologies, obviously we have a mechanism that decreases prices and increases access. It's very important to evaluate different technologies. Very often, the pressure put on governments, the high-cost medications end up having an impact on the sustainability of financing. And yet there may be other technologies for which there is no evidence for such and such pathology. So we have to end up developing stronger strategies, not only to provide greater access, but have regional methods for evaluating, assessing technology to determine whether it is beneficial or not. But we should not let that impact financing, otherwise there will be no benefits and it'll be irrelevant. Thank you, distinguished Minister Bisote, for reminding us about evaluating technology, behavioral changes, etc. We will now conclude by reminding you that before I call on the director for his final comments, that the epidemiological profile of the region is that the main reasons for mortality and death is NCDs. I think the message has been made quite clear. We have a great and beautiful tool that we can all apply, and PAHO is committed to working with all of you on this strategy. Mr. Director?
I'll be very brief, Marcos, because we need to go back to the plenary. I'd like to congratulate the three countries, Chile, El Salvador, and Jamaica, for sharing with us so much the important advances that they have implemented, and many others, such as those that spoke, Argentina, Ecuador, Bolivia, and those that don't speak all either. But they're strengthening primary health care to respond to the NCDs, because at the same time, we need to protect future generations with measures to reduce risk factors. It's also important to have that change in primary health care. I'd just like to underscore that, as you saw, this is an interprogrammatic effort, as underscored by our director, because here we are working through access to medicine and apparatus such as pressure cuff, and also with the funds and digitalization in health, HIV, guidelines and protocols, and M&E, and integration of primary health care with health services. In other words, it's an innovative look that will be reflected in a biannual work plan. Yesterday's initiative, elimination, and that of today, integrate NCDs in primary care, are two interprogrammatic activities, and we're going to mobilize the resources available as well as new resources to move forward faster in the region. So I invite you all to work together with that aim in mind. Thank you very much. Thank you all.
Gracias a todos y que tengan
Thank you all, and have an enjoyable rest of the day.